Two, one. Restart, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Hematology Up to Date. And with immense pleasure, I would like to invite Dr. Ankur Mittal, who is consultant hematologist and bone marrow transplant physician, Mohandai Oswal Hospital, Ludhiana, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, everybody, and I welcome all my colleagues and friends. And I'm really excited and elated to welcome you all for the today's academic session. So today our main focus is we would like to learn more and more regarding the recent advances and the latest updates in various hematological malignancies and the benign conditions. And we need to update with our latest treatment protocols and the managements for the better outcomes of our patients. So I'm looking forward for the interactive session and not taking much time. So I'm delighted to welcome our first speaker, that's Dr. Ravikant Porwal, who is going to speak on management of invasive fungal infections in hematological malignancies. Dr. Ravikant is a senior consultant and infectious diseases in charge at Manipal Hospital, Jaipur. Over to you, sir, Dr. Ravikant.
Thank you, Dr. Ankur, for your nice words. I'm just sharing my screen. I hope my screen is visible.
Yeah, sir, your screen is visible now.
Thank you. So,
Just make it, sorry to interrupt, just make it full screen.
yeah, it's full screen only at my side. You can't see it in full screen?
Yeah,
No, it's
sir,
not in display mode.
Can you see it now?
No, sir. Support team, can you help them?
Hello. Yes, ma'am.
Can you help doctor to make it full screen?
Yeah.
Yes, ma'am. Yes.
Are you seeing it in full screen now?
Sir, it's still in the display mode only.
Sir, can you please accept the request?
Okay,
Yes,
I've done
yes,
that.
Yeah, just a second. Sir, you have to stop the screen share and share it again.
Okay.
Yeah. Can you please share the screen again?
Are you seeing it?
No, not yet, sir.
Is it okay now?
No, sir.
So you can proceed like this anyways.
Yeah, sir, I think we can proceed with this.
You can proceed.
Yeah, because I really express my apologies for this technical glitch. At my side, I'm able to see it in a slideshow mode. Anyway, first of all, I must appreciate that the CME was started on time. And it is a very, very important topic as far as hematological setting is concerned, because you guys are the uh, I must say you guys are the main prescriber of antifungals in your immunosuppressed individual. So in another 20 minutes or so, what I'm going to do, talk only about relevant aspects about epidemiology, risk factors, some words about prophylaxis and treatment, and the finer nuances when we treat our sicker patients, what we definitely need to keep in our mind, and what are the problems in management. So, as we all know, that invasive fungal infections, specifically in your practice, carries a significant morbidity and mortality. And it is only a prolonged neutropenia setting, which by definition is more than a week. It's something which is really very, very important. If it is a very transient neutropenia, it doesn't really cause too much of problem as far as invasive fungal infections are concerned. So if I really look at what are the factors for this changing epidemiology of invasive fungal infections, is it really changing? Answer is yes, because there is increasing use of new molecules, keeping patients at a different risk of immunosuppression, and the host and environments are also changing. We know that now we are diagnosing hematological malignancies even at a younger age, and the environment is also changing. We saw COVID, a lot of steroid use, a lot of comorbid conditions. Not every hospital is equipped with the required engineering controls for treating these patients. And with the introduction of a kind of a broad spectrum mold active prophylaxis, there is a significant shift in epidemiology we are witnessing. Initially, it was either Candida albicans or Candida tropicalis, but now we are seeing little hardy Candida species like Oris, Himuluni, etc., and which will definitely have an impact as far as treatments are concerned. Commonly observed species of Aspergillus in our patients are Aspergillus fumigatus, but now there are more and more resistant species are actually observed in these immunosuppressed individuals. So we definitely need to know that the epidemiology is changing. It's not same as it was a couple of decades ago. And what is the impact on mortality if these speciations are really coming up and more resistant fungi are coming up? Then it will definitely have a steep increase in mortality because we don't really have too many tools to handle all these drugs. We all know that these kind of patients are definitely at a higher risk of invasive fungal infections, and you commonly see these patients in your practice. There's something called a D index, so whenever a patient is there and you are thinking about invasive fungal infection, it is the depth and the duration of neutropenia, which is the independent risk factor to mortality, I would say. Or when it comes to attributable mortality of invasive fungal infection, duration and depth of neutropenia has to be considered. And this timeline, I think most of you are very much familiar with, that in initial 1 month after hematopoietic stem cell transplant, it is only Candida, and later on your mold figures out as the top of the list as invasive fungal infections. The commonly used biomarkers and radiology, that is a very important and pivotal diagnostics for early detection of fungal pathogens. Commonly used test is galactomannan, which has variable sensitivity and specificity. But if it is a neutropenic, prolonged neutropenic situation and a compatible host, it will definitely give a lot of information about that particular patient. And when you see these macro and micro nodules on CT scans, signs like halo sign or air crescent sign, you are reasonably sure that my patient is having an invasive fungal infection. So when it comes to prophylaxis of invasive fungal infections, there are non-pharmacological interventions, which definitely each and every center should be using it, because they play really a very important role while managing these immunosuppressed patients. But this particular slide, I want all of you to pay attention, because this kind of a multitasking you definitely need to do before you are prescribing or creating a regimen of antifungal agent, be it prophylaxis or treatment. That what is the host condition, whether there are comorbidities, what are concurrent medication, and what is the PK/PD of the drug which you are going to use, whether it is azoles or echinocandins or something else. So it is a kind of a holistic approach. You need to run it like a checklist in your brain before you are actually choosing that particular agent for that patient. There are a variety of agents available, right from polyenes to azoles to echinocandin, and there are various different indications depending on fungal pathogens, whether it is Candida, Aspergillus, and Mucorales. What I would like to tell you is that
Sir, sorry for interrupt you, but your slide is not moving.
oops.
Garima, can we share the slides from our end?
Yeah, sure, sir. Can you please share on group, sir?
I'll just do that. Okay.
Sir, if you try to to the next slide, sir, if they're moving, then we can proceed like this only.
Is
Yeah,
it moving
it's
now?
moving, sir. It's moving now.
It's moving now?
Yeah, it's moving now.
Okay. Can you see it now?
Yeah, sir, we can.
Okay. I'm really sorry about it.
It's okay. I was messaging to others, and might be it was on my end, so everybody's replied me the same, so we disturbed you in between.
Is it moving now?
No, yeah, sir, it's moving now.
Thank you so much. So, so I was on this slide where I was talking about multitasking when you are actually arranging a regimen for your patients. And there are a lot of factors which you need to do consider while you are actually choosing a drug for your patient. And there are a variety of agents available depending on Candida, Aspergillus, and Mucorales. What I wish to tell you is that if you say that my patient is going to uh, mm, my patient has an invasive fungal infection, it is going to be a immature information for that particular patient. I would say the moment you think about invasive fungal infection, please think about etiology, because each ID problem has etiology. If it is Candida, your drug of choice or your drugs in considerations are going to be different, as if it is going to be mold or mucorales or something else. So please, depending on the timeline and risk factors, try and predict what is going to be the microbial etiology of your patient, whether they are going on and develop Candida or Aspergillus. When it comes to prophylaxis at a high risk for invasive aspergillosis, now the entire pendulum is swinging towards posaconazole. This is the IDSA recommendation in the setting of stem cell transplant, AML induction, etc. You all know about it, but there is a strong shift from voriconazole to posaconazole in this particular setting. When you think about fluconazole, what you need to understand that it does not have any mold activity. Fluconazole is an excellent drug for Candida possibility, but if you're really thinking of Aspergillus and other mold, it is not going to be serving the job. This is a recent recommendation by German Society of Oncology and Hematology. Again, says that posaconazole has a A1 recommendation. When it comes to mold active prophylaxis in invasive fungal infections, whether it has to be either mold active or fluconazole, these are meta-analysis published in the literature which clearly says that your patients are neutropenic patients and they have a higher risk of developing mold infection. So it has to be a mold active prophylaxis in your patient. Once you think about treatment, there is something called empiric therapy for your patient. Please pay attention to breakthrough fungal pathogens while you are thinking about empiric therapy, until the time you do not have a microbial etiology for your patient. Why I'm saying breakthrough infection? Because most of your patients are either on posaconazole prophylaxis or some sort of antifungal prophylaxis. So they will be having some or other fungal activity in that particular prophylaxis regimen. So you definitely need to think that what are the holes in spectrum of my prophylactic agent. So please pay attention to breakthrough fungus. And this is a very nice study published in 2017, which clearly told that quarter of Aspergillus isolates in this study had a lot of breakthrough fungus. Almost 43% was Aspergillus astus, and others were also there, like Niger, Teres. When I'm talking about these species, they do not have universal susceptibility to voriconazole or posaconazole. They have a differential susceptibilities, like Aspergillus terreus is even resistant to amphotericin B. So please think about different resistant species which may come as a breakthrough infection in your patient.
Dr. Ravi, sorry to interrupt you again. Please, you don't go to the slide mode. Means you remain in the same mode, because once you go to the slide mode, the slides stop moving.
Okay.
Yeah, now
Is it
it's
moving?
not. Yeah, don't go to the slide mode because the slide mode is not on the. It's not getting linked with the Zoom. So
Okay.
remain on this
Okay.
mode only and then proceed.
Okay. Okay. I'll continue like this. I'm extremely sorry, Dr. Ankur. Being the first
It's
presenter,
okay.
there are a
Some
lot of
technical
technical
issues.
glitches.
Yeah, there are technical, so it's okay. There's nothing like that. We are really sorry for that.
Thank you so much. And in this particular study, when I was talking about breakthrough infection, this is a study of allogenic stem cell transplant recipients, and they were all receiving a posaconazole prophylaxis. And you see that there are a lot of different species were there when actually they are not, developed the invasive fungal infections later in the course, like Neisser, Candida glabrata, Candida, uh, uh, other than albicans species, and most of these species are were resistant to posaconazole. So, since your patients are going to be on some or other antifungal prophylaxis, what you definitely need to consider that is there a possibility of breakthrough fungus in my patient. Coming to the treatment part of invasive fungal infection, I'll classify my talk on three different major fungus. One is Candida, Aspergillus, and Mucor. When you think about Candida, please try and collect more and more information about possibility of Candida, which you can do via Candida scoring. If there are multi-site Candida growth, like if there is a growth in sputum, in urine, or if there is a growth in blood, then definitely please consider your patient is having an invasive candidiasis. Using beta D glucan, if it is available, serves your purpose. If it is strongly positive, which means you are definitely dealing with candida. If your patient has a candida infection and your patient is unstable, first line empiric therapy is going to be echinocandin. When I say echinocandin, at the moment you have three choices: caspofungin, micafungin, and anidulafungin. Why I say echinocandin? Because it is a 1,3 beta D glucan synthetase inhibitor. This is an enzyme which is not found in mammalian cell wall, which means since this particular enzyme is not going to be there in our patient's body, this actually makes this drug virtually non-toxic. So if your patients who are sick, who have a certain degree of acute kidney dysfunction, hypotension, or sepsis features, this drug is going to be pretty safe in that situation. Yes, once you have a candida speciation and you know that what kind of species I'm dealing with, whether it is albicans, tropicalis, parapsilosis, etc., then you can definitely go for a definitive therapy if your patient's hemodynamics allows, and that is very important de-escalation once you have a definitive speciation. When we talk about invasive aspergillosis, which you commonly encounter in most of your neutropenic patients, as of now, the drug of choice or a preferred choice is triazoles. And the information which you are going to gather for your patient is by either by doing galactomannan or radiology investigations. And if you have a compatible clinical picture, think about invasive aspergillosis. As far as treatment is concerned, drug of choice is voriconazole. While as far as prophylaxis is concerned, for aspergillus and mold activity, posaconazole scores over. So this difference you need to consider. If you have a definitive aspergillosis in your patient and you actually want to treat that, voriconazole is going to be the drug of choice. Although if your patients are not responding, combination with echinocandins are actually used as a salvage regimen. Routine susceptibility testing for all the aspergillus species are not recommended because it is not commonly available at most of the center, and the suspected azole resistance actually dictates. Suppose if you have a lot of azole resistant species like aspergillus niger, aspergillus tereus, then definitely you need to do routine susceptibilities. There are two salvage regimen for invasive aspergillosis. One is either by liposomal amphotericin B if your patient cannot tolerate voriconazole, or a combination of echinocandin, like we discussed in earlier slide. This is a very important study, which I want to tell you all of you that when to change treatment while you are treating an acute invasive aspergillosis in your setting. As of now, we did not have much of information in the literature, but now we have clearly three important settings where you definitely need to think about changing treatment. One if your microbiological susceptibility testing says that it is a resistant pathogen to the primary agent. Suppose if you have chosen voriconazole and your fungus is resistant to voriconazole. Second, if you have given voriconazole for invasive aspergillosis, almost 1 week after the primary antifungal treatment, if you do a repeat galactomannan, either in serum or BAL, and if it is increasing, while the baseline galactomannan was negative, you definitely need to change the agent. Third, after 2 weeks of primary antifungal treatment, if your patient is clinically stable, but there are 2 serum galactomannan measurements which are continuously increasing, or if there is more than 25% increase in the radiological finding of aspergillosis, even then you definitely need to change. So these are the 3 settings where you start thinking about drug response, drug resistance, drug levels, etc. So there are these are the separate indications which you need to keep in your mind while you are treating your patients. Moving to the most difficult to treat fungus, that is called mucor. This is a very good study from mycosis group, which clearly told us that the drug of choice remains liposomal amphotericin B preparation, and it has to be in very high doses from 5 to 10 mg per kg. They clearly say that you need to avoid slow escalation of doses. There are a drug called isavuconazole and posaconazole. They are second line agent, although they actually they also recommend that if you assess the response after liposomal amphotericin B and there is a progressive disease or there are tolerability issues like toxicity issues, then the second line agents like isavuconazole or posaconazole can be considered upfront as compared to liposomal amphotericin B. Please remember that the data regarding uses of isavuconazole for mucor is not very strong as of now, and the PK/PD parameters of isavuconazole does not really favor using it as a first line agent. So it has to be used as a second line agent. Drug of choice remains liposomal amphotericin B preparation, which is a age-old antifungal agents against mucor. I would take you to this particular slide that there are still a lot of problems in management of invasive fungal infections, specifically in our country setting, because we have a lot of challenges at our setting. We do not have universal accessibility of therapeutic drug monitoring, which is a mandatory requirement if you are using a drug like voriconazole or posaconazole, which has a very narrow therapeutic window. There are different factors, different PK/PD, severe diseases. Your patient has a lot of drug interactions. So it has to be very, very strongly advised that if you are using voriconazole, you definitely need to be doing therapeutic drug monitoring, although it is not very commonly available. In this particular study, you can clearly see that if voriconazole was used as an antifungal prophylaxis, almost 18% was subtherapeutic, while 11% was supratherapeutic, which means around 30% of your patient, 3 out of 10 patients, will not have the desired drug levels. And that's really a significant concern in your immunosuppressed individual. Other thing is different antifungal drug-to-drug interaction. It is very, very important to know that drugs like posaconazole and itraconazole, they have a significant interactions with a simple drug like PPI, which is very commonly prescribed to all of these patients. There are other drugs like statins. They have interactions with other azole class, other immunosuppressions like tacrolimus and other things. And most of your patients would have something or other. So please pay attention if you really want that your patient have a desired outcome by these antifungal agents. This is again even a bigger problem that antifungal agents, as of now, whatever we know, they do not have a definite synergy except cryptococcus. So like we use in antibiotics, we give 2 or 3 different combination and do the job done, but there is not the case in antifungals like we are talking like in Candida, Aspergillus and mucor. Rather, in theory, there is antagonism if you use amphotericin B and azoles. So that actually creates a bigger problem while managing these patients. Even more, you guys are lucky that every other molecule is coming to you. and you have a lot of drugs to choose to your sicker patient. Eventually, there are lot and lot immunosuppressed individuals are going to be there, and probably you need more and more antifungals. But unfortunately, after 2001, when the one new class was discovered for antifungal called echinocandin, in last 2 decades, our antifungal pipeline is empty, and there is no new molecule is going to come in another 10 years time. So I would say we have an even more responsibility while we are using these drugs for our sicker patients, so that actually uh, we can uh, we can serve them better. I will just end my talk by this simple case, which will create a case why we are talking about all this. This was a small baby from a pediatric hematology, uh, B cell ALL post BFM day 17, and there was a palatal ulcer, and specimen was sent from palatal ulcer, and there was aseptate hyphae. So as we know that every hole in the palate is mucor, amphotericin B was started, but there was no improvement in that patient, and the patient was worsening. The palatal lesion was increasing, and later on, when we discussed with the micro lab, the growth in the micro was also not suggestive of mucor, and we were not able to identify the species. Eventually, we had to send this to reference lab to PGI Chandigarh, and they told us that it is not mucor, it is Xero hilum rostratum, and which was almost M4 resistant because MICs were nearing breakpoints. It was VORI resistant and posaconazole resistant. Thankfully, by that time, isavuconazole was available to us, and we used isavuconazole after discussing the reference lab, which was found to be susceptible. So I think with this case, we all know that there are changing epidemiology. There are more and more resistant fungus we are going to see in our patients, and we need to think deeper and deeper before we manage our patients with available antifungal agents, because we don't have much of the agents to choose from. I think with this, I
Hello,
will
sir.
just, yes.
Sir, kindly conclude your talk, please.
Yeah, I think this is my last slide. This is a take-home point that which we have already discussed. There are different agents in prophylaxis, as well as think about breakthrough fungus, and there are different agents as far as treatment are concerned. Thank you so much.
Thank you, Dr. Ravi, and it's really nice and interesting talk. Yeah, it's true that being a hematologist, treating fungal infections is a really tedious job, and sometimes, most of the times in AML or post-inductions, we lose our patients because of the fungal.
Correct.
That's the pity of the situation, that fungal cultures are not easily available. Sometimes it's very difficult to diagnose them, and the liposomal amphotericin, the cost is too heavy to the patient, that sometimes we are worried that yes, are we doing the right thing at the right time or not? Yeah.
Thank you, sir.
Yeah, thank you, Dr. Ravi. So let me see if there are any questions. Yeah. So not taking much time, so we are moving to our next session. The next session is recent advances and the role of ATG in aplastic anemia. And the speaker for the today is Dr. Pavan Kumar Singh. Sir doesn't require much introduction. We all know about him. He's a senior consultant and head of the department hemato-oncology and bone marrow transplant physician at Artemis Hospital, Gurgaon. Over to you, sir. And
yeah, thank you, Dr. Ankur, for arranging this wonderful meeting and inviting me for this talk. And I thank Bharat Serum also for the support, and they have provided the slides to me. I've made some changes in this, so I think my slides are visible.
yeah, sir.
Yes, sir, it's visible.
Okay, so I will start. So basically, the topic which I've been given is recent advances in the role of equine ATG in aplastic anemia management. So we all know that aplastic anemia ATG had been used for in almost, it is more than 30-40 years. So, and initially it was given with the combination with cyclosporin. So particularly equine ATG used in aplastic anemia The advances are there. Obviously, the addition of L-Trombopac to this immunosuppressive therapy regimen. So that is the only recent advances what we can see in the management of aplastic anemia. So the slides have been provided to me by Bharat Serum. I made some changes. Developing countries, these are the incidence. So age, gender, severity, distribution as per. So we can see that there is bimodal incidence, and as the age increases, both the incidence and the mortality rate increases. There are we see aplastic anemia. It is more commonly seen in 15 to 25 years of age, and then later on it is more than 60 years of age, male to female in the age group. So overall, if you see, almost equal incidence. So most of the aplastic anemia, it is non-severe type. Then these are the severe aplastic anemia, and very severe aplastic anemia are less common, less than 10%. So genetic correlation, we normally in routine of practice, we usually don't advise NGS or molecular based methods for testing genetic abnormalities in aplastic anemia. But in the studies, it had been shown that these are the commonly mutated abnormalities, which are DNMT3 and ASXM1, which is seen in aplastic anemia, MDS, and sometimes other associated abnormalities. And other one is the PIGA and BCOR mutations. These are other common mutations which are seen in aplastic anemia, but they are less commonly seen in MDS, because sometimes we see a overlap between aplastic anemia and MDS. Older patients are more likely to have these mutations. Etiological factors. So category wise, if it decides it is basically antibody induced. Sometimes it is associated with some autoimmune diseases. Then aromatic compounds. These are the risk factors. Drugs, particularly antibiotics, not in use nowadays, and the chemotherapeutic agents, they are likely to cause aplastic anemia. And these are other drugs which can lead to aplastic infection. Especially to mention is these are viral infections like CMV, EBV, seronegative non-A, non-B type of hepatitis. Then it is also seen with the hepatitis B associated aplastic anemia, and these are other conditions, and then radiations. So these can also lead to. So this is the typical picture of overlap syndrome taken from Neil Young paper, and it is seen that aplastic anemia, these are other associated features, associated diseases which can be associated with aplastic anemia like PNH, LGL, MDS, and then it can progress to AML. Hypocellular MDS also comes into this, and other telomere diseases. So these are the manifestations. Like, so initially, so in this, if we see lower down in on the x-axis, y-axis, it is the T cell immunity. So and here it is B cell immunity. So autoimmune hemolytic anemia, ITP, these are particularly associated with B cell immune mediated destruction, and the lower down like PRCA, PNH, HLH, aplastic anemia, megakaryocytic thrombocytopenia, and these are usually associated with T cell mediated destruction of hematopoietic stem cells. So similarly, this is the pathophysiology of acquired aplastic anemia. So basically, it is T cell mediated destruction of the hematopoietic stem cell, which leads to pancytopenia and aplastic anemia. So that is how these are the pathways which are targeted for the treatment. So classification we all know, initially given by Kamita in 1975. Then it was made some modification by Basiglupo in 1988. So we all are familiar with severe aplastic anemia, very severe and non-severe aplastic anemia. So so now coming to the treatment. So there are three modalities of treatment, if you see. So it's mainly the stem cell transplant. For all those who are eligible for less than 40 years, we can consider increasing the age to 50 years also nowadays, if there is matched sibling donor available. So they should go for allogenic stem cell transplant, because it is the standard of care. And for any reason, if the patient is not fit, or if there is no match, or if older patients, immunosuppressive therapy is the next standard of care, and which includes ATG plus cyclosporin, and the recent approval of L-Trombopag combination with this immunotherapy, so immunosuppressive therapy, which increases the response rate and overall outcome of the disease. And the other is for those who are not, for any reason, if these two options are not there, then other is the supportive care in terms of blood transfusion, which can be given to these patients. Now, we all know about these guidelines for, they have made the guidelines for children and for adults, separate guidelines. It is mainly based on the age. The age cutoff had been because of the improvement in the transplant outcomes in aplastic anemia. So that is why nowadays almost up to 50 years also people are considering for bone marrow transplant age if matched sibling donor is available. And for those where there is sibling donor is not available, then immunosuppressive therapy plus minus L-Trombopag, we usually response is seen in 3 to 6 months. If suppose treatment failure is there, then patient can go for alternative donor transplant, either haplo or mud or cord blood transplant. Then for adult patient also almost kind of similar uh, uh, algorithm. So, but in adults, a second immunosuppressive therapy can also be given, and if there is treatment failure, then can go for allogenic bone marrow transplant, and then they are being followed up. So almost this is also same kind of algorithm. So initial management and so age 40 to 50 years also nowadays people are considering for match related donor response. Even more than 50 years also can also be taken up for bone marrow transplant as per the Eastern Mediterranean EMBMT group, and the EBMT also is recommending for those patients with very good performance score. So survival, if we see, so relative, this is a 5-year survival rate, almost 65%. This is the real world data from Sweden and in the aplastic anemia. So for those who are less than 60 years of age and those patients who are 60 years and above. So patients who are 60 years and above, they have survival less as compared to those patients who are less than 60 years. So difference is 85 versus 45%. So age effect, age is very important factor for patients receiving immunosuppressive therapy. So for very young patient, 1 to 20 years, the response rates are almost more than 80%, and 21 to 40, 60, 70%. And for more than 40 years, almost 60% of these are the days from the initiation of immunosuppressive therapy. So if we see bone marrow transplants, so these are also kind of similar kind of transplant outcomes as per the EBMT data from 2001 to 2010. So for unrelated donor transplant, best outcome had been seen for patients who are very young and where the first line unrelated donor transplant was considered. So now coming to the ATG plus cyclosporin, the mechanism of action, we all know that basically it targets the T cells, so antithymocyte globulin also, and this is which causes basically targets T cells by pan T cell markers, and the cyclosporin, we all know that it's a calcineurin inhibitor, which inhibits the production of IL-2 mediated T cell proliferation and differentiation. So these are the calcineurin inhibitors like cyclosporin and tacrolimus. Most of the studies have used, and conventionally cyclosporin is the drug which is preferred with immunosuppressive therapy regimen. And for ATG, we have two options, equine and rapid ATG, but mostly it is used, equine ATG is being used. So these are the mechanism of action. So ATG survival up to 10 years. So this is the survival data. So nowadays, if you see the use of ATG plus cyclosporin as compared to earlier when it was used, so nowadays the outcomes have improved a lot, and it is almost in the range of 70%, the 5-year survival probabilities for those patients who had been given ATG plus cyclosporin between 2000 to 2007. So horse ATG, this plus cyclosporin, and rabbit ATG also is being used. So red one is the rabbit ATG, which is used. and it is all retrospective analysis as a first-line therapy in severe aplastic anemia. So the response to horse ATG and so the overall survival in this study, horse ATG versus rabbit ATG. So overall survival 96% in horse ATG group as compared to the 76. This is a Philip Sheenberg paper and uh, uh, published in NAGM. And after this publication of this result, so nowadays rabbit ATG is almost gone for the treatment of immunosuppressive therapy in aplastic anemia based on this paper. So there is clear overall survival advantage in horse ATG group as compared to rabbit ATG group. And these are the other parameters which have been shown to have beneficial effect, like increase in blood counts in patient with hematological improvement. It was better with horse ATG versus rabbit ATG in terms of absolute reticulocyte count, absolute ANC, and platelet count. So studies confirmed better response with horse ATG, superiority of horse ATG to rapid ATG in other studies, also small Russian. So that was not the only paper, and there are several other studies which led to the use of horse ATG as standard of care in aplastic anemia as immunosuppressive therapy. So durability of response, this is also better, and it has improved life expectancy and durable hematological response. So this is another immunosuppressive therapy horse ATG comparison of responses in various studies. So when there were other agents added to, so we can see that the response rates are almost in the range of 60 to 70% with horse ATG plus cyclosporin. So people have used adding of other agents to this regimen and whether there can be the improvements can be improved. So in fact, with addition of these agents like GCSF, danazol, erythropoietin, mycophenolate, sirolimus, so actually this didn't make very much difference in terms of response rate, overall survival rate, event-free survival rate, or the relapse rates. So this was the study, the use of ATG plus L-Thrombopag, the combination treatment for severe aplastic anemia. It improved responses by preventing the cytotoxic T lymphocyte-mediated attack on hematopoietic stem cell cells, and also causes boosting of stem cell function through thrombopoietin growth factor signaling. So this is the mechanism of action. This L-Thrombopag. So there are multiple ways of mechanism by which it induces the hematopoietic system, and that is how it is used. So these are the first line phase 1-2 study. Then this is the phase 3 study, and so then later on, so higher survival rate of patients in ATG plus L-Thrombopag group versus ATG alone, and a higher effective rate of ATG plus versus ATG alone in these studies. So Indian experience in immunosuppressive therapy with horse ATG. So there are various studies, those small numbers, but this study, so ATG, so they have type of ATG. Mostly it is Thymogam, and then Pfizer Adgam also is being used. The overall response rate of this regimen, if we see, it is almost in the range of, as I said, 60 to 70%. So the response rate of Thymogam in adults is similar to that. So in these studies, the outcome of Thymogam was found similar to Adgam, though there was some infusional reaction. And if we see overall comparison, if we see the cost wise, Thymogam is very much cheaper than the Pfizer Adgam. So this is another study, immunosuppressive therapy, single center experience from Western India. So horse ATG manufactured by Bharat Serum and at a dose of 40 milligram per kg for 4 days was given, and cyclosporin standard dose at given at 10 mg per kg. So these are the results. So at 2 years, the response rate in this study was not so good, almost 23% and 40% in children. So equine ATG and cyclosporin in aplastic PGI Chandigarh experience at 3 months and at 6 months, overall response almost 77% at 6 months. So Another in children. So again, the ADG standard dose given at same dose, the response rate in children was almost 70% with CR rates of 3.3% and partial response was 65%. Here it was the thymogam which was used. So another study, the complete response rate is 21%, so over 32% was the partial response. The overall response rate was 53% in this study, another in pediatric patients. So another equine ATG in pediatric patient, the overall survival it was 85%. And GCSF was also used in children, but it fails to offer any survival advantage. So now this is another, this study from a tertiary care center from India, from AIMS. It was addition of L-Trombopac to the immunosuppressive therapy regimen, that is ATG plus cyclosporin. And if we see, the overall response rate was 75% in Indian cohort. So almost total number of patients were 38. And we can see that with the use of indigenous ATG and the response rates were 75% at a median follow-up was almost 1 year. So immunosuppressive therapy, triple regime, thymogam, cyclosporin, and L-Trombopac. This is again prospective observational study, total 11 patients. And it was thymogam which was used. The overall hematological response rate was 72%. This study of 11 patients was from our center we used in Artemis, and this has published also, was published by in the EHA meeting by Ragesh. And the overall response, the hematological response rate, what we observed in this was 72%. And 7 patients received platelet counts more than 20,000. And the median time to response was 8 weeks for the platelet. And 54% achieved neutrophil count recovery.
Sir, sorry for interrupting. Can you conclude your talk?
Yeah, this is my final slide. So I will just here. So finally, to conclude that horse ADG and cyclosporin, it is considered as the standard of immunosuppressive therapy for aplastic anemia. And for those patients who are unfit for, or for any reason, if they are not candidate for bone marrow transplant, a immunosuppressive therapy is the second standard of care. And addition of L-Trombopac to this current regimen, it is very effective. Overall response rate, we can achieve more than 70%. And in our set of resource poor setting, indigenous thymogam by Bharat Serum is the response rates are almost equivalent to the Pfizer AdGam. Thank you.
Thank you, sir. Thank you so much for your talk. Next session is sponsored by MCure. Now, I would like to invite Dr. Ankur Mittal, sir. Sir is a consultant hematologist and bone marrow transplant physician, Mohandai Oswal Hospital, Ludhiana. Please start, sir.
Before I start, I would like to pay thanks to Pawan sir. Pawan, really, it was a nice talk, and we always think that transplant is the treatment of choice for the aplastic anemia, but somehow our patients, because of the high cost of the transplants, they end up with this session only on ATG. And even though with having triple immunosuppression on board, the response rates are very good, and most of them they do better. Before they proceed with the transplants, I think 90% have received ATG.
Yeah, it's good, but still we consider bone marrow transplant because the relapse rate. The problem with ATG and the immunosuppressive therapy is the relapse rate.
Yes, sir.
So relapse rates are quite significant, almost in the range of 30 to 40%. So that is why still bone marrow transplant is considered as the gold standard, and I agree with that. But yes, for those patients where it is not possible, immunosuppressive therapy should be given.
Sir, one question which sometimes comes in my mind, like if the patient has a haplomatch, and will you proceed with a haplomatch transplant or with ATG as first line?
No, not haplo, not upfront, unless patient is like very severe aplastic anemia or ANC is 0. In those patients, yes, you can consider.
Yeah. True, sir. Right, sir. Thank you, sir. Thanks for the time and thanks for the discussion and the session. So I'll proceed with my talk. It's a very general talk on the pericarboxymaltose. So are my slides are moving? The slides are moving or not?
Yes, sir, it's visible.
So I'll be discussing on the pericarboxymaltose, the management of iron deficiency anemia and its optimal use of parenteral therapy. So we all know that still in India that 53% of all Indian women have anemia. And India ranks the highest most as 170th out of the 180 nations in women who are suffering from anemia. And with the different the incidence of anemia amongst different population subtypes are different. And as we can see from this slide that in lactating women, the pregnant woman and the reproductive age woman, the percentage of anemia is different and it varies from year to year. Like in 2016 it was 58% and now it's gradually decreased to 40% with the more and more awareness in the Indian population. So the incidence of anemia has decreased, but still it's there. And about two-thirds of all anemias are iron deficiency anemia, and the rest includes the other causes of anemia like megaloblastic or hemolytic or aplastic anemia. But in the iron deficiency anemia is also there are terminologies in which we say it's an iron deficiency, that is a functional deficiency of the iron, and the patient is have suffering from iron deficiency anemia. So we all know the morphological picture of the PBF that these anemias are microcytic anemia. This varies on the MCV, that is the size of the RBCs. If it is less than 80, is microcytic, and if it is more than 100, it is macrocytic. Between 80 to 100, it is normocytic kind of anemia. And if we discuss about the symptoms of anemia, especially the iron deficiency anemia, there is heartbeat palpitation is there, dizziness or lightheadedness, poor appetite. The patient may have headache, extreme fatigue, shortness of breath, brittle nail, and cold hands and feet. So these are the common presentation. So if we say regarding the pathophysiology of iron deficiency anemia, is it all depends on that we know that iron is absorbed at the small intestine. Whatever the dietary uptake is there, it is absorbed in the small intestine with the help of ferroproteins and DCYTP and DMT1, which is regulated by hepcidin, which is secreted from liver. So this iron absorbed goes to the liver and then it is metabolized and it is given shifted to plasma iron and then it's interchangeable and then it goes to the other tissues, macrophages and the red blood cell. So what is iron deficiency anemia? The iron deficiency anemia is a hypochromic microcytic anemia and the red blood cells are abnormally small with low level of hemoglobin. Despite the causes, the iron deficiency anemia occurs when the body iron demands exceeded that of its supply. And there could be two types that either the stores are depleted, it could be metabolic or functional. So the inflammatory response of the body in response to infection may also contribute to an acute form of iron deficiency anemia as the demand is increased. And how quickly the iron deficiency anemia develops, it depends upon the cause and the stages. So what are the causes of iron store depletion? Either it is an inadequate dietary intake or there is an excessive blood loss. So whichever the diet which is deficient in the iron rich diet, if the patient doesn't have much non-vegetarian diet or beans or iron fortified diets, so they have the low iron stores because the intake doesn't fulfill the demand. Or when there is an excessive loss, either due to some hemorrhage or menorrhagia, heavy menstrual bleed. So in that we lost the blood. In one sense, we are losing the iron from the body. So the demand increases. Otherwise, if we say the metabolic and functional cause, either it is insufficient iron delivery to the bone marrow or there is impaired use of iron within the bone marrow. So if the stores are inadequate, they can't meet the body need. So the mechanism is the delivery to the bone marrow is utilized to the RBCs, but it is impaired. But in impaired use, the iron stores are adequate, but they can't meet the body's need because they are not processed or used in the bone marrow for the RBC formation. So in inflammatory response, due to the immune effector mechanism, the cytokine activity, the nitric oxide formation, and the T cell proliferation, so the requirement of the iron increases in the body, either because of the pathogens may require to survive. So we have three stages of the stages of development of iron deficiency. So how it develops? First, the body iron stores are depleted, but the RBC production proceeds normally with the hemoglobin content remaining the normal. Then the reduced iron transfer to the bone marrow, which causes an iron deficiency in the RBC production. And next, the small hemoglobin deficient cells, they enter in the circulation, which replace the normal RBCs. So at this time, we have the microcytic picture. So now we have two types, like either it is an absolute iron deficiency or the functional iron deficiency. So in absolute iron deficiency, the insufficient iron store is available. The deficiency may be because of either inadequate intake or chronic blood loss. While in functional iron deficiency, the adequate iron stores are there, but they are not adequately used by the erythroids. So there is decreased maturation of erythroblast and there is reduced response to erythropoietin stimulating agents. So in functional iron deficiency, the ferritin levels are normal, while in absolute iron deficiency, the ferritin level is low. But whereas T saturation is a differentiating point, if the T saturation is less than 20, and this is called the functional iron deficiency, while if the T saturation is more than 20, so it is absolute iron deficiency. Sorry for the typographic error. So what are the different scenarios and what are the lab reports which we generally feel? So first is the normal, then we have a negative iron balance, but the hemoglobin or the iron stores are okay. So next is a poor erythropoiesis, and then last is the iron deficiency anemia. So in first we have adequate circulating iron stores in first three, while in the last iron deficiency, the circulating iron stores has markedly reduced. So if we say in the normal terminology, the serum iron is okay, the transfer saturation is okay, while TIBC remains in the normal limit. As we progress further, gradually the serum ferritin levels start decreasing, and the total iron binding capacity start increasing, and the serum iron starts decreasing. While the saturation, it's initially it's normal, and then it start decreasing. So how we manage all these? One is the absolute iron deficiency anemia. Then either it becomes the inflammatory related or chronic kidney disease. And the next is mixed in which absolute iron and the iron deficiency. The absolute iron deficiency anemia usually managed either with oral or IV. IV is only recommended when there is poorly tolerated oral therapies or there is malabsorption. While in CKD, IV is the preferred. Similarly, with anemia of inflammation, the IV iron therapies are preferred. In mixed therapies, either oral or preferably IV. Sorry. So, what are the various iron stores which iron deficiency can be managed? So, either with the dietary advice, then is the oral iron therapy, and next is the IV. IV can be given either IM or intravenous, and the last is the blood transfusion. We discuss one by one. What are the disadvantages and advantages? So, in the oral iron therapy, we know we require it about 4 to 6 months of treatment to achieve the desired hemoglobin level, and the treatment compliance is not very good, and there is a poor absorption from the GI tract, and the adverse events like the GI side effects may occur with the oral iron therapy. While with the blood transfusions, as with all blood transfusions, the risk of transmitted infections is there, then the trolley and other factors could be there. And what are the advantages if we talk about the oral iron therapy? That is cheap, it is very cheap. And if we discuss about the side effects, yes, it has GI side effects in terms of GI upset, nausea, diarrhea, or sometimes dark stool or constipation. And sometimes the oral iron may have vomiting and faintness too. If we discuss regarding the benefits and the risks for the blood transfusions, the benefit is it's the rapid increase and the rapid improvement in the symptoms. But whereas the risks, there are thrombotic events could be there, the transmission of viral infections could be there, congestive heart failure due to the over fluid transfusion reactions, GVHD or trolley, bacterial contamination, iron overload, and potential to reduce the survival. So the parental iron therapy, the next is parental. So parental can be given IM or IV. We are giving IV. And if we talk about the timeline of intravenous iron, so it comes from iron saccharides and high molecular weight iron products, and gradually then iron sucrose, ferric moxitol, and now the ferric carboxymaltose and iron isomaltose since 2014. And I think after the having ferric carboxymaltose in the prescription pads, the treatment and the results with the iron deficiency has markedly improved. So the first generations are like iron dextran, and then the second generation is gluconate and the sucrose, and the third generation is carboxymaltose and isomaltosol. So what are the risks and the benefits? So IV iron is more effective and better tolerated. And it's very important in the patients who have excessive bleed, late pregnancy, GI intolerance to the oral therapy, who have impaired absorption or irritable bowel diseases. So in all these cases, the IV iron therapy is preferred over the oral. So coming to ferric carboxymaltose. So if we see the three dimensional conceptual structure of this, we came to understand that it is a stable molecule and it is formulated as colloidal solution with physiological pH. Due to the stability of this complex, FCM does not release ionic iron under the physiological condition, and that is why the transfusion reactions are very less with this. The iron hydroxide is tightly bound with the carbohydrate cage, within the carbohydrate cage. So these are the ideal preparations of side effects and the tolerabilities and the doses which are there with the ferric carboxymaltose in comparison to other. And we all know that ferric carboxymaltose for the test dose is not required for the ferric carboxymaltose. So these are the various studies which has depicted the efficacy of ferric carboxymaltose in iron deficiency anemia. I'll come few of the studies later on, and in all these studies they have suggested that with ferric carboxymaltose within 3 weeks or 6 weeks, the rise in hemoglobin is about 3 to 4 gram as compared to the oral substitutes. These are the various studies. So within 6 weeks, there is a significant increase in the hemoglobin levels from the pre-FCM to the post-FCM. This has been depicted by the various studies in the previous slides. And this has been seen in all the cases, either it is an iron deficiency with severe anemia, with moderate anemia or mild anemia. But whereas the patients who have iron deficiency with no anemia, there is marginal increase in the hemoglobin. As we have discussed, the stores are adequate in these cases. So with the oral therapy, the things can be done. So if we compare ferric carboxymaltose with the hemoglobin level or versus the oral, so we can see the ferric carboxymaltose gives a rapid increase in 86% of the patients, which increases the hemoglobin level in 3 weeks as compared to the oral ferrous sulfate. These are the various side effects which has been seen with the ferric carboxymaltose against the ferric sulfate. As we can see from this, the most of the side effects are commonly with the ferrous sulfate, but whereas headache and injection site reactions are more there with the ferric carboxymaltose, and there is decreased serum phosphorus has been seen in patients who have received FCM as compared to the oral therapy. But in general, this has a lower adverse events as compared to the oral. So, and this is the trial between, this is that this is the comparison between iron sucrose and FCM, and we can see that with the ferric carboxymaltose, the results, the rise in hemoglobin is comparatively better as compared to iron sucrose. So the toxicity profile is also better with ferric carboxymaltose as compared to iron sucrose or ferric gluconate or iron dextran. I even don't remember for how long I have used iron sucrose. So what are the indicators? What are the indications? So indications are very important. Like FCM, IV iron therapies are only recommended when it is indicated. Otherwise, we should always prefer the oral. So when there is intolerance to oral iron, when there is inadequate response to the oral iron, then we need to have a rapid response. Either the patient is planned for some elective surgery or is the later part of the pregnancy. In the postpartum anemia, in menorrhagia or any other bleeding, inflammatory bowel disease where the oral therapy will not work much, in cardiorenal syndromes or CKD patients or anemia of their anemia of systemic diseases there. What are the advantages? It is effective.
So, sir, kindly conclude your talk in 1 minute, sir.
Relatively free of from adverse events and no test doses needed and no GI intolerance. What are the various advantages? It's the ease of administration is there, hence it is recommended for primary care, and it's cost effective, and we avoid the need for the dangerous blood transfusions and reduces the EPO requirement. These are the dose calculations, and this is an easy way to calculate the dose. We are not using Ganonzi's theorem right now. So with hemoglobin and body weight, the iron can be given. And the tolerance is excellent. There is hardly any adverse events which is there, but hypersensitivity reaction, hypophosphatemia should be kept in the mind. And this is the most prescribed IV iron. And now we have 1 gram, which can be given as single dose and with less time. This is all which I need to discuss for the today's. So
Thank you, sir. Thank you for your talk, sir. Any comments, any questions? Now we move on the next session. This session is sponsored by J&J. I would like to invite Dr. Mubin Mittal, sir. Sir is a senior consultant and HOD, Department of Medical Oncology, Patiala. Welcome, sir. Mubin, sir, you need to unmute.
Yeah. Hello. Good evening, everyone.
good
Myself,
evening,
Dr.
Dr. Mubin.
Mittal, medical oncologist and hematologist at Amar Hospital, Patiala. Today, my topic is deep and durable response in the frontline myeloma with novel agent. We will mainly focus on the daratumumab. Next slide, please. Daratumumab is a human monoclonal antibody directed against the CD38. By binding to CD38, daratumumab inhibits the growth of tumor cell by inducing apoptosis. Next slide, please. Daratumumab as a novel agent, mainly two studies are there. One is the Cassiopeia trial, another is the Graphene trial. First, we will discuss the Cassiopeia study. What is the Cassiopeia study? Cassiopeia study compare the VTD, which is the usual regimen, with the daratumumab along with VTD. Initially, the newly diagnosed cases of the multiple myeloma are taken into consideration. They randomized for the induction therapy for the VTD and the DVTD arm. The arm containing the daratumumab. Then MRD was done. Then autologous transplantation was done. Then further consolidation was done with the 2 cycles, and then the maintenance therapy was done with the dara versus observation. This was the basic schema of the Cassiopeia trial. This is a phase 3 trial. Next slide, please. Then what are the endpoints and the statistical analysis point in the Cassiopeia trial? One is the PFS. PFS in the DARA arm, PFS was improved with the HR of 0.58. And the fewer death rates were reported with the DVTD arm. That is the 41 versus 73%. While comparing to the side effects are more such as neutropenia, lymphopenia, pneumonia seen in the DARA arm. While the infusion related reactions such as are noticed in the DARA arm from 15 to 25%. Next slide, please. Then we are comparing the MRD negativity. MRD negativity rates were more with the DARA arm, both and post consolidation, as we can clearly see from the bar diagram. Next slide, please. This is the basic schema of the study. Basic schema: post induction and post consolidation. 85 patients not randomized to the maintenance therapy. So we left with the 886 patient. Out of that, 442 patient received the maintenance daratumumab versus 444 patient was under observation. Median follow-up of the study was 35.4 months from the second randomization. Next slide, please. Rates of the MRD negativity was more with the DARA arm at 1 year and 2 year, as we can clearly see from this bar diagram. The next slide, please. MRD negativity post-induction and post-consolidation more in the DARA arm, as we can see from this diagram. Then subgroup analysis. Coming to the subgroup analysis, as we can see, the
significant result was seen in the high risk. Means if we are using in a newly diagnosed case of multiple myeloma with high risk feature, we are using VTD, DVTD, means DARA along with VTD, then it's more effective and more MRD negativity can be achieved. As this can be seen from this forest plot, the high risk population achieved much more benefit as compared to the standard risk. Then what are the Cassiopeia trial conclusion? MRD negativity rates and sustained MRD negativity rates were significantly higher after DVTD induction consolidation versus VTD. Patients who achieved MR negativity post-induction and maintained MR negativity post-consolidation have improved PFS. Of patients who achieved both post-induction MRD negativity and post-consolidation MRD negativity, receiving DARA in maintenance further improved the outcome compared to the observation. DARA VTD followed by DARA maintenance lead to the numerical highest MRD negativity rates. In VTD treated patients, DARA maintenance significantly improved the MRD negativity compared to the observation. Longer follow-up is needed to adequately assess the PFS and OS benefit of sustained MRD negativity for DARA versus observation after DVTD induction and consolidation. Ongoing studies are there, such as Griffin and Perseus and Origa, and the data is further more studies are also required to support this data. Then next slide, please. Then our next study was Griffin trial, in which the standard RVD it was compared with the DARA along with the RVD. RVD is the standard of treatment, that is the lenalidomide, bortezomib, and dexa. That is along with the daratumab. Initially, the patient were newly diagnosed cases of multiple myeloma, randomized between the VRD versus DARA along with VRD. Initially, the forced induction cycle were given, then followed by the transplant, and followed by the consolidation for 2 more cycles, then followed by the maintenance along with the DARA and lenalidomide versus lenalidomide alone. This was the basic schema. It's a phase 2 trial. Next slide, please. This slide clearly shows that the demographic and clinical characteristic shows that treatment arms were well balanced. We can see that the VRD and DVRD arms both have the almost equal patients as compared to the age, stage, and baseline creatinine and risk factor, high risk or standard risk. Next slide, please. This slide clearly shows response rate were greater for the DVRD versus VRD at all time points, with the deepest response occurring after 2 years of maintenance therapy with daratumab. Next slide, please. MRD negativity after 2 years of maintenance therapy with daratumab is approximately 81%, while with the VRD, that is nowadays usually the standard of treatment, is approximately 44%. Next slide, please. This slide has been already explained. MRD negativity rate improved throughout the DR maintenance period. 29% of the DVRD patients and 12% of the VRD patients who were MRD positive at the end of consolidation became MRD negative after 2 years of DARA and lenalidomide alone maintenance therapy respectively. Then DVRD improved the rate of durable MRD negativity last can be seen at 6 month and 12 months interval. As previous slide, please. Previous slide. DVRD improved the rate of durable MRD negativity at 6 month and 12 month, as can be seen from the bar diagram. Then next, please. Median follow-up here was the 38.6 month. Median PFS was not reached in either group. The separation of the PFS curves begin beyond 1 year of maintenance and suggest a benefit of prolonged DR therapy. That is DARA and lenalidomide therapy for prolonged duration more beyond 1 year is benefited. Next, please. Median follow-up was 38.6 month. Median OS was not reached for either DVRD followed by DARA and lenalidomide or VRD followed by lenalidomide. The OS data are not yet mature. Then coming to the next slide, please. Coming to the side effect part. Neutropenia, thrombocytopenia, leukopenia, anemia, all are the side effects that are more seen in the DVRD arm, that is more with the DARA arm. But peripheral neuropathy is a side effect which is more seen in the VRD arm. Rest all side effect, nausea, vomiting, constipation, almost equally seen in the both arms. Next slide, please. That is the infections: upper respiratory infection, pneumonia, URTI, sinusitis, influenza, nasopharyngitis. That is more commonly seen with the DARA arm. That is the VRD arm. What are the conclusions from the Graphene trial? These results support DARA plus RVD as induction, post autologous stem cell transplantation consolidation, and DARA on lenalidomide maintenance as an effective regimen for the patient with the transplant eligible newly diagnosed multiple myeloma. MRD rates highest for the DVRD followed by DARA and lenalidomide. DVRD followed by DARA and lenalidomide have deeper level of the MRD negativity and greater rate of sustained MRD negativity were higher for DVRD followed by DARA and lenalidomide versus VRD followed by lenalidomide. While this study was not covered for PFS, there is positive trend towards the improved PFS in the DARA VRD followed by DARA and lenalidomide group versus VRD followed by lenalidomide group, with separation of the curve beyond 1 year of maintenance, which suggests benefit of the prolonged DR therapy. The addition of DARA for 2 years of R maintenance was well tolerated overall. These data suggest that phase 3 PERSIST study of DVRD followed by DR maintenance therapy compared with the VRD followed by lenalidomide alone is that in a transplant eligible newly diagnosed cases of multiple myeloma. That's it. Next, please. These are the conclusions which has already been explained. In short, DVRD is the regimen of choice for fit patient of multiple myeloma newly diagnosed with high risk cytogenetics, if patient can afford.
Thank you, Dr. Mubin, for the nice talk on daratumumab in multiple myeloma. As we all know that having dara in the prescriptions and sometimes having the targeted therapy, the results are better. So if there are any questions or any queries, okay. So then we can switch to the next discussion. Yes, we are running on time. We're lucky enough. Yeah. So thank you, Dr. Mubin, again, and thank you, Johnson and Johnson.
Thank you, sir. Thank you, sir.
So our next session is the advances in genetic testing, which is used in the treatment of AML. So Dr. Charu Bahal, she is the chief in MedGenome Labs, who generally reports the nuclear gene sequencing panels. And it's very lovely to have you on board. And I generally discuss my cases with Dr. Charu whenever I have clinical queries to discuss with her. So she always discuss in details and give us some clues regarding the further. So over to you, Dr. Charu.
Yeah, thank you so much, Dr. Ankur. A very good evening to all. So probably I will be discussing on the genetic testing front of AML today. So there are some interesting cases which I would like to discuss, and some also the new updates which are around AML which we have. So the agenda includes genomic technologies, some genetic aspects of AML, and certain case studies. So as we know, genetic testing has become a very important part of oncology-based oncology treatment, be it risk assessment, be it differential diagnosis of the in terms of wherever we have a confusion regarding the diagnosis, be it prognosis in terms of how the disease is going to behave and what will be the progression as per the biomarkers that are present in the patient, and most importantly, selecting various therapies on basis of the biomarkers which are becoming more and more prevalent these days. Then we have therapy monitoring, and then we have definitely using the genetic based testings as a surveillance tool also, in terms of looking out for relapses and recurrences in certain aggressive disease conditions. So genetic mutations, as you know, there are different types of mutations that we could find. Some are point mutations, which are just single base pair change, which can be detected with the help of next generation sequencing. So next generation sequencing can detect point mutations, that is a single base pair mutation. And if we want to look at the smaller deletions and smaller insertions, which are 1, 2, 3, or 4 to 5 base pairs, that could also be detected with the help of NGS. However, when we come to larger deletions that are more than 1,000 base pairs, or there are larger duplications, for that we will need MLPA, or even fragment analysis, which is done by PCR based technique. And NGS here has a lower sensitivity to detect deletions and larger deletions and duplications. So next, coming to the important genetic abnormalities, translocation, which is very common in leukemias. So translocation, when it happens, is there is exchange of genetic material between two chromosomal locations, and hence it affects the protein which is being formed. One of the common example is 922 translocations, or here I have illustrated 420. So these can be detected with the help of multiple techniques. One is karyotyping, FISH, RT-PCR, and one of the upcoming one is NGS, which is RNA based sequencing, because we are looking at the fusion proteins which are being formed at the mRNA level. So NGS based RNA sequencing is a very specific tool to look out for translocations. So now coming to AML, as we all know, it's a very complicated and a complex disease with a high variability in clinical features, pathogenesis, and treatment outcomes. In adults, it accounts for 80 to 90% of acute leukemias, and incidence is higher in males as compared to females. almost 95% of the AML patients have some driving or concurring mutations regardless of presence of cytogenetic abnormalities. So other than cytogenetic abnormalities, almost 95% of the AML patients will have a certain driving mutation and certain mutations which are called secondary or concurring secondary mutations. Now, if we look at karyotyping, how it indicates the prognosis in AML patients, patients who are having pure hyperdiploid karyotype have an adverse risk irrespective of number of chromosomal gains. Second important thing is patients with translocation 911 have an intermediate risk independent of the number of additional aberrations. So, and patients having more than 4 abnormalities have an adverse risk per se. However, patients who have 3 aberrations and in the absence of abnormalities of strong influence such as hyperploid karyotyping, 911, CFM, AML, and unique adverse risk aberrations, they have a borderline intermediate or adverse risk with a reduced OS as compared to patients with a normal karyotype. So that's why karyotyping in AML has a role to play while looking at this risk stratification and categorizing the patient as a poor or adverse or a better prognostic group categorization. Now, how are we using genomic testing in case of AML? So there are 3-4 important points which I would like to discuss. One is inherited genetic predisposition. Second is mutations that are detected at different stages of patient's treatment. Third is clonal evolution. And fourth one is minimal residual disease, which is MRD. So genetic predisposition of AML is not a very commonly seen thing, but it is not rather that very less common too. I mean, these days I have been witnessing a lot of cases where we find germline mutations in ETV6 and TP53 or other such related genes, which lead to hematopoietic neoplasms in both myeloid and lymphoid lineages, and they lead to disruptions in these genes and result in malignancies such as AML. So for in the purpose of detecting these mutations per se becomes important in terms of when you are looking at prognosis of the patient before or after your hematopoietic stem cell transplant, and also their response to the therapies. So, and whenever you are selecting donors for these patients, so detection of these kind of mutations becomes all the more very important. So as per the new 5th edition of the WHO publication which has come around the categorization of myeloid neoplasms. These are the 3 main categories which have been identified by in this new guidelines. So myeloid neoplasm with germline predisposition with pre-existing platelet disorder or organ dysfunction, something like germline SEPA or germline DDX41, germline TP53, germline RUNX1, germline ETV6, GATA2, so bone marrow failure disorders, rasopathies, Down syndrome. All these are, I think, becoming more and more important in terms of when we are looking at familial AML cases or cases where it is a AML which is as a result of certain underlying condition. So definitely, I think it becomes more and more important to take these points into consideration when we are looking at these kind of patients. Now, we definitely know AML as a genetic, as a disease has a very variable and a very complex genetic alteration mapping. You can find subgroups under single group of mutation, like in a PML RARA positive patient, you can have an FLT3, ITD2, WT1 also. So, and in an MPN1 patient, you can have an IDH1, IDH2 also, a TET2 also, and a RAS and RAS also. So, a highly complex genetic abnormality, molecular make a kind of a molecular phenotype phenotype is found in these kind of patients, and it becomes important to stratify the patients up to a level where you know all the mutations that are present, because after a point of time certain secondary mutations become the driver mutations when you are targeting only a single driver mutation. So as per the new classification, there are few new entities they have added in the defining the genetic abnormalities category for AML. So the new categories which they have added are revolving around three rearrangements, which is KMT2A, MECOM, NUP98. So these are three categories which have been recently added, and also there are few additions in terms of risk stratification. So AML which is defined by mutations include AML with MPN1 and AML with SEPA mutation. AML with MPN1 mutation can be diagnosed irrespective of the blast count, and also AML with SEPA mutation has now been changed to include biallelic SEPA as well as single mutations in the BZIP domain. So these are the favorable prognostic markers now, which are demonstrated in cohorts of children and adults up to 70 years of age. So these are 2-3 important points which they have added in terms of stratifying the patients and creating the categories of AML as per the genetic abnormalities. So the two new categories which have been added is BZIP domain mutated SEPA, and the adverse category they have added the mutated RUNX1, ASX1, BCORS, E2Z2, all these genes as a poor or you can say adverse markers for AML. So these are the new risk stratification additions in the risk stratification classification for AML. Coming to FLT3-ITD and FLT3-TKD, these are two important mutations that have definitely therapeutic implication in AML disease. So FLT3-ITD per se is found in the ITD in the domain where there is an addition of internal tandem repeat, and certain base pairs are added to this particular region, which becomes important in terms of because it can now basically respond to midostaurin, which is an important drug which is used these days. We are doing FLT3-ITD by fragment analysis and also by NGS. So fragment analysis will give you proper allelic ratio as per the ELN recommended guidelines, and NGS also measures the allele burden, but in a slightly different manner in terms of variant allele frequency. So those two have not been clearly correlated, but definitely in terms of taking the therapy progression and taking the disease progression into consideration, FLT3-ITD by NGS has also been seen to be quite established and quite successful at our lab. Now coming to genetic evolution, which we can measure with the genetic testing that we can do for AML patients at different stages of treatment. So when we are testing the patient at the diagnosis, after the induction therapy and after the consolidation therapy, then definitely we can look at the percentages of the mutation that were present at the start of the treatment and after the induction and after, even after the stem cell transplant. So the presence and absence of different mutations with different percentages can very well help you establish the the clones which are coming up, and that really helps in terms of predicting the prognosis and deciding the further course of action for the patient. The last important point is MRD and relapse. So as per NCCN, you have to look for MRD assessment using real-time quantitative PCR for major translocations and some major mutations like SEPA and MPN1. However, in case of relapses, you can look at mutation status of the genes which are detected at the start of the treatment, like FLT3, ITD, TKD, and IDH1, IDH2. And also comprehensive molecular profiling is recommended by NCCM. Now, NGS for minimal residual disease monitoring has a very important advantage in terms of assessment of disease-related mutations. Definitely, residual leukemia-specific mutations in bone marrow in a morphological CR after induction therapy represents the source of relapse. So, if there is a mutation that is there in the bone marrow even after the morphological CR is attained, that can really help you understand that there is still chances of relapse in that patient, and also helps you to understand in terms of your bone marrow transplant which you are going to perform in that patient or not. So superiority of NGS based approach have been seen in clinical studies, and very recently at MedGenome we have also started doing the same. I will be just discussing the cases in the next few slides. So now coming to my case studies in terms of how we are using genetic testing and our DNA and RNA based panels to look at the patients and tracking their molecular evolution in AML. So this is a 31-year-old female diagnosed with AML, tested at two major intervals at diagnosis and post-induction. So FLT3, ITD, and IDH2 were detected at baseline. After the induction, there was no clinically relevant mutation found. This is just the first follow-up sample which was done for this patient. So secondly, this is a very interesting case where there was a 32-year-old male diagnosed with AML in complete remission, and post BMT, we had looked for both point mutation and translocation because he had relapsed after the bone marrow transplant, and we could find that there was a WT1 mutation with a low with a VAF of 42% and a NUP98 and NSD1 gene fusion, which was detected by RNA based NGS. So WT1 is associated with poor outcome and poor overall survival. As a result, NUP98 and NSD1 fusion also contributes to cell immortalization and results in AML. So if this testing would have been done prior the BMT, this would have already been detected, but this was done after the BMT. So we could not even track that the patient already had it, or he developed it after the BMT. So it becomes important that we look at all these markers before we are going into the process of bone marrow transplants, and it can really help to understand the course of prognosis the patient will have. So next is also an important example of germline predisposition. So this is a patient, 43-year-old female, treated for AML post 7+3 HIDEC 3 cycles, pancytopenia, and MRD by flow is 7.2%. So post-induction, post-MRD, BMA was tested for comprehensive leukemia panel, and we could find a CBL mutation at 53.8%. Variant allele frequency, which is on the higher side. So also the patient had a history of neoplasm in the past. So the CBL testing was done in germline setting to establish whether the patient has CBL syndrome, and it was found to be positive. Then because the patient was being planned for allogenic transplant, prevalence of CBL was confirmed in germline testing using buccal swab testing in the patient, and possible donors who were sister and daughter were also evaluated for the same variant. So I could also find a similar kind of case study in British Journal of Hematology, which was published in 2021 itself. So this also highlights that absence of developmental defects and non-neoplastic phenotype do not always exclude the possibility of AML due to germline predisposition that typically represents in young patients. So,
Sorry for interrupt you, ma'am. Can you conclude your talk within 2 minutes?
Yeah. So just moving to, I think the last two case studies. One is a 40-year-old AML patient who were tested at the time of diagnosis only with DNA-based mutation panel and RNA-based testing, which is our heme track panel. We could find a KRAS mutation, which is obviously giving indication towards poor prognosis, and a CFB MYH11 gene fusion. So this is a combo panel which gives you both DNA and RNA based results, and you can get one-stop solution for both types of alterations at one time. Now, this is the case study which I really wanted to discuss, which is AML MRD by NGS. So we did NGS profiling for this patient. He's a known case of AML. We did it on in December 2021. We found a TP53 mutation at 62.2%. And after the first follow-up, we again got the sample on 6 July 2022. We did a high depth sequencing at around up to you can say 3,000x, and we found that this variant is still present at 0.1%. The overall depth for 4803x, which is 4,803, and we could detect these mutations at such a lower depth. However, if you look at the AML MRD for this patient by flow, it was negative. So this information was helpful for the clinician to continue the aggressive treatment so that he can get rid of TP53 completely. So all in all, this is our main focus of AML in terms of next generation sequencing, FISH and RT-PCR. We have all the techniques available, and we are looking at finding the best possible prognostic and diagnostic therapeutic implication for the patients. So that was all from my side. And if there are any questions, I will be happy to answer. Yeah.
Thank you, Dr. Charu, for the nice presentation. And it's really sometimes feels amazed that now gradually we are moving to molecular MRD. So
yeah, we have just started, sir. So it's been a good experience till now. We are working on it. So let's see. Yes.
If we are going for a molecular MRD, so do you need the previous sample also to be done at your lab, or the first report could be from any other lab and you can?
If it is done with us, that's really good in terms of we can do not have that background noise if it is done with us only. But even if it is done with some other lab, we can run the sample at a higher depth, because we are running it at almost 5,000x. So kind of it is error corrected only, and it will be very specific for that particular mutation.
Right.
So, yeah.
Thank you, Dr. Charu. I'll discuss one more case with you on telephonically. It's a Hodgkin's lymphoma patient not linked to this presentation. So I'll discuss that case with you later on.
Definitely, sir. Definitely. Thank you so much. Thank you, Dr. Ankur. Thank you, everybody. Yeah.
So thank you, everybody. And at the end, I would like to extend my sincere gratitude to all the faculty delegates who have logged in for the great discussion and the learning today. I would like to acknowledge all our academic partners for the generous support to execute the webinar. But at the end, I just want to tell you that don't forget to log in again for the tomorrow, and tomorrow morning around 10 a.m. We'll restart our discussion on leukemia parts and the lymphoma parts, and we have a panel discussion on the follicular lymphomas. Thank you, everybody. I'll not stand in between to your dinner, so you can go ahead. Thank you, everybody, and thank you, support team. And